Welcome to Medical Specialists Associates educational series on topics in critical care medicine. I'm Christopher Voss, MD, MS, board certified in anesthesia, critical care medicine, neurocritical care medicine, and pain medicine. Necrotizing soft tissue infections are severe, life-threatening infections characterized by rapid destruction of the skin, subcutaneous fat, fascia, and muscles. Despite being relatively rare, NSTIs carry high mortality rates ranging from 10% to 20%, with minimal improvement in outcomes over the past 20 to 30 years. As critical care physicians, understanding the diagnostic challenges, surgical interventions, and antimicrobial management is vital to improving patient outcomes. 1. Classification and microbiology. NSTIs are broadly categorized into Type 1, polymicrobial, and Type 2, monomicrobial infections. Type 1 NSTIs are more common, typically affecting immunocompromised or older patients and involving a mixture of aerobic and anaerobic bacteria. Type 2 NSTIs, caused predominantly by Streptococcus pyogenes, group A Streptococcus, or Staphylococcus aureus, affect otherwise healthy individuals and usually involve the extremities. Two additional subgroups include Type 3, Vibrio, Aeromonas Clostridium, and Type 4, fungal infections. Prompt recognition of the bacterial etiology is essential for the targeted use of antimicrobials. 2. Pathophysiology and clinical presentation. The clinical severity of NSTIs stems from a combination of bacterial toxin production and the host's immune response. Bacterial toxins induce local ischemia and tissue necrosis, fostering an environment that impedes antibiotic efficacy and promotes bacterial proliferation. Inflammatory mediators and toxins often escalate the condition to septic shock, necessitating ICU care. Clinically, NSTIs typically present with nonspecific symptoms such as swelling, pain, erythema, and warmth, which can mimic less serious infections such as cellulitis. However, signs like violaceous skin, necrosis, bully, and crepitus are classic, though seen in less than half of cases. Risk factors include diabetes, cardiovascular disease, obesity, chronic liver disease, and intravenous drug use, though up to 25% of patients may present without underlying conditions. 3. Diagnosis. Early diagnosis is crucial but challenging. The laboratory risk indicator for necrotizing fasciitis score uses 6 variables: white blood cell count, hemoglobin, sodium, glucose, creatinine, and C-reactive protein to assist in diagnosing NSTI. While the Nawijn F score is a helpful tool, its sensitivity varies, 49% to 75%, and clinical suspicion should always take precedence. Imaging studies, such as CT scans, can help identify subcutaneous gas and fascial thickening. However, radiologic evaluations should not delay surgical intervention. The necrotizing soft tissue infection score has recently shown promise in clinical trials, providing better diagnostic accuracy than Nawijn F by incorporating clinical features such as systolic blood pressure, skin changes, and white blood cell count. 4. Surgical management. Early surgical debridement is the cornerstone of NSTI management, with the goal of removing all necrotic tissue to prevent further spread of the infection. Delays in debridement, beyond 12 hours, have been associated with increased morbidity and mortality. Guidelines advocate for debridement within 6 hours of suspected diagnosis, as early intervention significantly improves survival rates. Repeat surgical exploration should occur every 12 to 24 hours, and source control should be achieved as soon as possible. In some cases, skin-sparing debridement may be considered, but only when overlying tissues remain viable. 5. Antimicrobial therapy. Empirical broad-spectrum antimicrobials should be initiated immediately, covering gram-positive, including MRSA, gram-negative, and anaerobic pathogens. Typical regimens include a broad-spectrum beta-lactam, such as piperacillin tazobactam, MRSA coverage with vancomycin or Zyvox, clindamycin to inhibit bacterial exotoxin production in suspected toxic shock. Antibiotics should be continued until surgical debridement is complete and clinical improvement is evident. Duration of therapy varies but can be as short as 48 hours post-source control or up to 7 days, depending on patient recovery. 6. Adjunctive therapies. The role of hyperbaric oxygen therapy in NSTI remains controversial, with limited evidence suggesting lower mortality rates but no effect on amputation. The Infectious Diseases Society of America, IDSA, does not recommend routine HBOT use, and if considered, it must not delay surgical debridement. Intravenous immunoglobulin may be beneficial in streptococcal toxic shock syndrome, though randomized controlled trials, such as the INSTINCT trial, have shown no significant benefit. Its routine use remains unsupported. 7. Future directions. Advancements in genomics and proteomics offer potential future diagnostic tools. Machine learning models using ICU data have shown promise in predicting mortality and other outcomes in NSTI patients. Biomarker studies, including cytokine profiling, are actively being explored to enhance diagnostic and prognostic accuracy. Conclusion: NSTIs are a critical condition requiring a multidisciplinary approach and aggressive intervention. Timely diagnosis and surgical debridement, combined with broad-spectrum antibiotics, are paramount to improving survival rates. Continued research into diagnostics and treatment strategies will likely shape future management guidelines. To learn more about critical care medicine, please visit us on our website at medspecialists.net and subscribe to our YouTube channel.